I was teaching basics of electrocardiography to first year medical student. He had never seen how ECG recording is done. He did not have any prior knowledge regarding ECG, and I told him that in our routine clinical practice we do 12 lead surface ECG. 12 lead means like we have 6 precordial leads and 3 augmented leads, and there are other 3 leads, lead 1, 2 and 3. So while I was explaining, he told me that he understood that precordial leads detect electrical activity in horizontal plane. You imagine your heart in 3 dimensions, just as in anatomical position. So the left ventricle is directed inferiorly and laterally like that, and electrical activity that is originating from SA node traveling to the AV node, then to the ventricles via those bundle branches fascicles. Those electrical activity we record in ECG, and those electrical activity, there is summation of those electrical activity, and we get net vector that is recorded in the ECG, right? So he told me that he understood that these 6 precordial leads can see the heart from this side, right? But if you want to see heart from this side, we can place electrodes on this side as well. Yes, definitely we can place electrode anywhere. You can look heart from here, you can place the electrode here. If you want to look heart from below, you can place electrode here. You can place anywhere, you can place on the back. So you should be knowing how electrical activity is being conducted through those conducting tracts in 3 dimensions, and then you can place electrodes anywhere and you can deduce how conduction is occurring. And those precordial leads, if you place either in the front or the back, they look the heart in horizontal plane, or you can say transverse plane. But is there any way to look heart in vertical plane, in coronal plane? This we call coronal plane, right? So if we place electrode here, right, it can somewhat assess electrical activity in coronal plane, but we do not have any way to place the electrode in the inferior portion of the heart. So is there any way? That's what Einthoven thought. How can we look inferior portion of the heart without doing invasive study? If you place electrode in the right ventricle, if you go through the jugular vein, superior vena cava, and place in the right ventricle, you can definitely record from there. That's what electrophysiologists do. They do invasive study. But Einthoven thought that, do we have any idea? Can we think mathematically, and we can deduce some formula so that we can look heart inferiorly with surface ECG. And in Thoven triangle. So from there the concept of lead 1, lead 2, lead 3 and augmented leads came, and it is a long formula. I won't discuss it here. This is a separate topic. So from there the concept of looking heart in coronal plane came. So it is not looking structurally but electrically. So when we are talking electrocardiography, basically we are studying electricity of the heart, how conduction system is working in the cardiac tissue. So 2-3 AVF look at inferior portion of the heart, right? If you understand in Thoven triangle, then you will know 2 is directed like this and 3 is directed like this, and AVF is like looking from the left foot to the bottom of the heart, inferior portion. So these 2-3 AVF look at the inferior portion of the heart, and lead 1 look at the lateral wall of the heart, as V5, V6 look at the lateral wall of the heart. Similarly 1 also look at the lateral wall of the heart, and AVL look at the high lateral wall. So this is the lateral wall, and high lateral wall electrical activity is recorded by AVL. And what is the use of AVR? Is there any use of AVR? We do not often talk about AVR tracing when we discuss ECG. Because whatever the electrical activity is occurring in lead 2, it will be exactly opposite here, because the vector is exactly opposite, right? So 2 is going in this direction and AVR is going in this direction, right? So whatever the pattern of tracing you see in lead 2, it will be exactly opposite in lead AVR. So in lead, you know, there is P wave and there is predominant QRS in positive direction, and T wave is also positive in lead 2. So in lead AVR, P wave is negative and there is predominant negative QRS vector, and T wave is also negative in AVR. So as we discuss other leads like 2-3 AVF, AVL 1, we do not often discuss AVR, because whatever the study we get from AVR, we can get from lead 2 as well, as it is exactly opposite. So this is surface electrode ECG. So definitely this standard 12 lead ECG has many limitations. It can miss ischemia, it can miss arrhythmia, it can miss WPW syndrome, because the heart is located deeply and it has to travel fibrofatty tissue that is covering the heart. Then there is lung on both sides that is interfering. Then there is a skin, bone, right? So all the electrical activity of the heart cannot travel to the surface to detect it. Definitely we cannot ignore the value that this 12 lead ECG has added in medical field, but there are many limitations, and to overcome those limitations, electrophysiologist what they do is that they directly put the leads in the chambers, in the right atrium, right ventricle, in the coronary sinus. So in the coronary sinus they record electrical activity of the left atrium, posterior wall of the left ventricle, because coronary sinus is situated directly on the posterior surface. So if you put the lead in the coronary sinus, it can record the left atrium, left ventricle. So the sensitivity of EPS study will be obviously more as compared to surface ECG.